Welcome everybody to this evening's presentation. This evening we're doing the who, when and how of starting insulin, thyroxine and vitamin D. So there's a fair bit of information to get through. Dr. Executive, so hopefully we'll achieve what we're doing today. Our presenter this evening is Dr. Algenes. He's a second-year advanced trainee in diabetes and endocrinology at the Townsville Hospital. Next year he won't be in Townsville, but in 2014 he aims to return to Townsville as a full-time consultant. This evening our sponsor is Pfizer, so thank you to everyone speaking to Pfizer for seeking sponsorship. For those of you who don't know, the emergency exit is where you came in, and there's toilets around the corner there. And at the end of the meeting, if I can just remind you all to fill in the evaluation of what you thought of this evening and any other topics that you might want for 2012-2013.
Thank you, Dr. Bala. Good evening, everyone. My name is Algenes. I'm the advanced trainee in endocrinology at Townsville Hospital. And I was asked to speak on 3 topics today. It's my pleasure to talk about starting insulin in type 2 diabetes patients, starting thyroxine in hypothyroid patients, and starting vitamin D in vitamin D deficient patients. So first thing about type 2 diabetes, as you all know, we started with tablets first, diet and exercise first, and go on to insulin at a later stage. So you may ask, how long later stage? How long is this later stage? Well, almost all patients with type 2 eventually fail to respond to tablets, and we are facing an epidemic of 1 million patients of diabetes in Australia, and our referral system is actually backward by 2 or 3 months in Curtin Hospital and even in the Townsville Hospital. So we think that it may be possible for some of the GPs to possibly even start insulin in the community at small doses whilst the patient is waiting for their clinic appointment. So let's have a look at what happens to normal individuals. So in normal individuals, if you look at this graph, this is the night time, this is the daytime. You have plotted, it's exactly the same graph, top and bottom, and it's total body insulin. When you eat dinner, your insulin gets secreted in response to your dinner. And look at the normal subjects, how nicely it goes up, and look at the diabetes subjects, how badly it goes up. And again, when you eat your breakfast and your lunch, in normal people, for all of us, it goes up well, but for the diabetes subjects, it doesn't go up so well. So the more common problem is when and how to commence insulin in type 2 diabetes. And this is called secondary failure. And secondary failure means you're not responding to your tablets anymore. And how long does it take to reach secondary failure? In other words, what can you tell your patients when you first diagnose them with type 2 and you tell them, I'll start you on tablets, diet and insulin. And then they ask you, oh doctor, we need to go on insulin at some point. When is that bad day going to come? So to give them a number, there was this excellent study in the UK called UKPDS, and they found out that 44% of subjects on tablets after 6 years went on to have insulin. So as a rough ballpark figure, this can give you an idea in your mind. About 6 years, half of all your patients on tablets will go on to insulin. And this is just a slide to show how quickly your mean beta cell declines in terms of functionality over time. And when you first diagnose people, they already have type 2 diabetes, they will already have 50% deficiency in their function of their beta cells. So by the time you get to 6 years, it goes down to a quarter of what it usually was. So how do you start insulin for patients with type 2 diabetes? We're going to use the International Diabetes Federation guidelines for the first bit of the talk. So according to these guys, in 2005, they said that insulin can be started as a basal insulin alone or with pre-mixed insulin. So what is the meaning of basal insulin? Basal insulin, all of us secrete tiny amounts of insulin. To go back to the graph I showed in the beginning, all of us secrete tiny amounts of insulin even when we are fasting, but very tiny amounts, to the order of 2 to 3 milliunits per liter. And when we eat, it goes more than, 2 to 23 milliunits per liter. When we eat, it jumps about 23 milliunits per liter. It goes up to 50, 100. That's how we normally produce insulin to digest our food. But in type 2 diabetes subjects, it doesn't happen. So we give Lantus insulin, which is the same as basal insulin, which covers someone for 24 hours. And what's this other word we used? Premix. Premix means the insulin consists of at least two components, a rapid acting component and an intermediate acting component, usually in ratios of 30 to 70 or 50 to 50 or 25 to 75. And so it is pre-mixed, it is already mixed, and that's how it got the name pre-mixed. And when to start? When to start, they like to use the ballpark figure of HbA1c of 7.5%. So when you have reached maximal doses of your oral tablets, and when your HbA1c is consistently 7.5%, that's when we need to consider insulin. And so the IDF came up with this flowchart, which is available on their website, wherein you start lifestyle intervention and tablets, and HbA1c is more than 6.5%, you can go on to sulfonylureas. HbA1c more than 6.5%, and you can go on to thiazolidones. But if it's more than 7.5%, you can go on to insulin. Now, thiazolidinediones have got a bad name, and you must have read about it in the press. They cause bladder cancer, they cause retinopathy, and they cause heart failure and myocardial infarctions. So if your patient has a heart attack and comes out and has thiazolidinedione, which is pioglitazone, prosiglitazone, they should be stopped. If your patient has heart failure and they're on the glitazones, they should be stopped. And if your patient has bladder cancer, yes, we must stop your pioglitazone. Now, younger age patients already on maximal oral therapy and as much lifestyle modification as they manage would benefit greatly from long term with early introduction of insulin, even if the HbA1c is only mildly above 7%. And the important point here is early introduction of insulin, because when you're young, and if you leave them too long with HbA1cs of 8%, 9%, 10%, they get complications. And briefly, just to mention something about insulin and C-peptide levels. Supposing you have a patient who is losing weight, that means they are ketotic. A type 2 patient who is losing weight is ketotic. And in those circumstances, we as clinicians sometimes measure insulin and C-peptide levels. And if these levels are low, it means we know the patient is insulin deficient and we start them on insulin. But we use this only in rare circumstances. Most of the times you can tell just by HbA1c, and that's all I would advise on this talk. To keep it simple, just the HbA1c is what you can use as a guide to find out if someone needs to go on insulin or not. There are exceptions. We recently had a 43-year-old man. He came to us with type 2 diabetes, and he was quite angry and saying, why should I come to your clinics anymore? I don't have diabetes anymore. My insulin requirements have fallen down to 0 because I'm losing a lot of weight. I've lost 10 kilograms in the last 3 months. And he looked at his liver function tests, and they were all deranged. And he was only 43. But intelligent consultant Dr. Sangler, lateral thinking in his brain, thought, could it be a neoplasm? And he did a CT abdomen with the patient, and there was a colorectal neoplasm. Only at the age of 43. So there are catches to it. So if some of your patients are losing weight rapidly and they don't need as much insulin as they can as before, almost all suspect could there be possibly a malignancy. Now this man was only 43, but he could easily be a 70-year-old patient in the community. Now when you come to the geriatric age group, and to be politically correct, I'd like to take the number as 85 at least, more than the age of 85. I have a couple of patients on the wards right now who are both over 85 years of age, who are nursing home residents, and both of them have dementia, and I was asked to dose their insulin. And what I did is I just gave them once a day Lantus and kept it really simple, and just said avoid hypos, because an elderly dementia patient cannot detect hunger and may not be able to tell you that I'm hungry and I need to eat food. So giving Novorapid 3 times a day with a fixed dose might be difficult for an elderly patient. You could do it with a small safe dose like 4 units 3 times a day, but what I like to do for the elderly patients is not to get too aggressive. That's a bottom line message. Not to get too aggressive with their diabetes control, and even HbA1c is 8 to 9% is quite acceptable for that age group, and that is because their prognosis is governed by macrovascular, not microvascular complications, and it's not greatly influenced by their glycemic control. Now when you come to the choice of insulin regimen, the combined oral drug and insulin approach, so many patients and doctors procrastinate insulin treatment because it's erroneously considered to be difficult and risky in the community. But such regimes are used routinely in our clinic and are easy to start. Now yes, we have the benefit of diabetes educators, but I would like to possibly ask you to even ask the patients to refer to our diabetes educators in our clinics. and I'll come to that very soon in the talk. So in our opinion, these regimens of early dosing of insulin and small dosing and safe dosing can be started in the community. So which insulins can you possibly use? So I'll talk about 3 insulins today. One of them is Glargine, which is Lantus, that's the Sanofi-Aventis company. Isophane, which is Protophane insulin, which is the Novo Nordisk company. And another Novo Nordisk insulin, which is Novofix 30. And you may ask me, what is this? What's Aspart and what's Protamine? Now, Aspart is nothing but your Novorapid, and Protamine is a compound where insulin is joined with a product from the fish, which gives the insulin a longer half-life. So this insulin is, Aspart is nothing but the Novorapid, the rapid-acting component, which is just the same as Novorapid. It's 30% of the insulin, and the 70% component is the other insulin, which is longer acting and goes up to 12 to 14 hours. And how long does Lantus work? Anyone in the audience? How long does it last for? It's 24 hours. And how long does Protophane last for? Protophane peaks about 8 to 10 hours, but it also lasts for 24 hours. But the good thing about Lantus is it's a very small peak, just above the baseline. It's a very, very shallow peak above the baseline, constant for 24 hours. Now what's the first type of regimen you want to use? Lantus or Protophane? So for practical purposes, the patient can always be commenced with 8 to 10 units of intermediate or long-acting insulin just before bedtime or as late as possible. Now you may ask me, is 8 units safe? Is 10 units safe? The answer is yes, because these are abnormal subjects. They don't have enough insulin from their pancreases. They don't have enough insulin from their beta cells. So giving such a subject 8 units of insulin is safe. Whereas giving me, who does not have diabetes, and if I have worked a long day and I haven't eaten my dinner, and if I take insulin, I will fall hypoglycemic. Because my pancreas normally produces insulin, it's doing its job appropriately. Whereas in a diabetic subject, it's inappropriate, it's not doing its job. So if someone has an HbA1c of 7.5% and you're giving 8 units of insulin, it's totally safe because they're not giving enough insulin for their own bodies. Now the timing of insulin, you may ask me, why are you giving it at night time? The reason for that is something called counter-regulatory hormones. Consists of cortisol, growth hormone, epinephrine. They tend to get secreted in our bodies between 4 o'clock, 5 o'clock, 6 o'clock. Our cortisol levels are highest at 8 in the morning. And these are counter-regulatory hormones, which mean they make you insulin resistant. And that's why if you give the insulin at night time, it takes care of this counter-regulatory hormone. So you're very less likely to get a hypo between the hours of 4 o'clock and 10 o'clock. But it's very important the patient eats a dinner. And how much insulin to start with? And some patients may be very nervous, understandably, and reluctant. And therefore it's imperative to minimize the risk of hypoglycemia in these individuals, however small. And therefore a slightly lower dosage can be used to get the process underway and to gain the patient's confidence. And patients who have hypoglycemia can start at a higher dose of insulin, but they really need 20 to 25 units per day. Now you may ask me, in type 1 diabetes, what is the dose of insulin? Now many things in medicine we go by the body weight. Many drugs are all dosed on the body weight of the subject. So type 1 diabetes subjects, usually they need 0.5 to 1 unit per kg body weight. As you know, type 1 diabetes is autoimmune attack of the islets. That's the etiology. So the islets are totally finished. So they have no insulin at all in their body. So 0.5 to 1 unit per kg body weight is the normal requirement. What if I told you a type 1 diabetes subject needs 1.5 units per kg body weight insulin? What thoughts would go through your mind? That means the patient is probably obese in addition to type 1 diabetes. That obesity is causing insulin resistance, and that's why they need that extra 0.5 units above their kg body weight. What about type 2? How much do they need? Usually they say, the literature says about 0.5 to 0.8 units per kg body weight, up to 1 unit per kg body weight per day of insulin is what they usually need. But many of our subjects are obese, and I do have patients in clinic who are on 200 units of insulin per day, and that's not wrong. But this talk is all about starting insulin. So to start insulin, 8 to 10 units is very safe starting dose for your patients, and by the time your referral gets reached to the hospital and our clinics in Kerwin and Townsville, by the time I get to see them, they will have had good benefit from the insulin you have started. They would have got used to insulin, then I can attack it more, and I can do all kinds of variations. If you started Novamix 30 once a day, I can start it twice and twice a day and really get their HbA1c under control in my clinics. And if you started them on Lantus, I can add in Novorapid or Humalog 3 times a day, and I can really up and down it with the help of diabetes educators and get them done really, get in control really well. Now, what are you going to tell to your patients on the day they start insulin? So at this stage of diabetes, most patients would be familiar with glucose monitoring, that is fingerprint glucoses, and they should be asked to perform it when they start insulin. It's quite imperative. As adjustment of insulin dosages in this regimen is primarily dependent on the morning fasting glucose. If you take insulin at night, testing at the morning time should be done every single day. But it's best done 3 times a day. But in the ideal world, many patients are not able to do it 3 times a day because of work commitments. So it's best to take a middle ground. The patient is happy and the doctor is happy. And that's in keeping with the principles of evidence-based medicine. So nowadays we're moving into this zone of evidence-based medicine. We're looking at evidence from journals, and using the best evidence, and we're treating our patients. And the right way of using evidence-based medicine is to take your best knowledge into consideration, plus the best evidence out there from the journals, plus the patient's values into consideration. And when you join all the 3 together, you get a very strong alliance, which is almost an unbreakable alliance. And that's called how to actually implement evidence-based medicine on your patients. Now we'll go back to the talk about hypoglycemias. Hypoglycemia is the only risk in starting insulin therapy, and however much the risk is minimized, it cannot be totally eliminated. So how much to inform patients is sometimes difficult for you. Too much detail might scare away the patient, and they might not want to take insulin at all. But not telling them too much might open you to medical litigation. So it's reassuring that in patient with type 2 diabetes, hypoglycemia due to insulin is usually not very severe, as opposed to type 1 patients where it is really severe. And how to initiate your insulin dose, your first dose. So they have a number over here, it's 0.2 units per kg body weight. It is your initial dose to start them on. And this number is the same for both Novamix 30 insulin and for Lantus, 0.2 units. And I've got nice flowcharts later on to show you how it will be done. So if you do 0.2 units, how much would that be in an average 70 kilogram male? If I use 0.2 units, that will come up to it's about 6 to 8 to 10 units per day, to 12 units per day. So 8 to 10 units is quite appropriate in such people, so that would be appropriate starting dose. And what changes to take place? Now they say after 2 to 3 months, the patient is likely to be around, say, 30 units of insulin each day. I'll come on later slides how to increase it and how quickly to increase it. And measuring HbA1c concentration after this interval helps to quantify a new level of glycemic control, and further increases in insulin dosage can be made accordingly. And if you have succeeded in reducing the HbA1c, great, you can stay on the same dose. There is generally a reduction in HbA1c of about 2% and an increase in body weight of several kilograms. And that's a bad effect of insulin. It makes you put weight. And that's what's called a vicious cycle. Now, your patients may not get it because they're starting for the first time on insulin, but some of our hospital patients are very obese. And they come to my clinics sometimes not eating the right diet, and they don't tell that to me. They say we're eating the right diet, and sometimes it's not their fault. They suffer from depression and they get antidepressants. And all of you know, olanzapine is infamous for insulin resistance. It worsens your diabetes by insulin resistance. So what we do is we increase the doses of insulin even more, and they put on more weight, and that causes more insulin resistance, and then next time they come to clinic, they need even more insulin. So that's a vicious cycle. And sadly, that's quite unavoidable. But now we have a new surgery called bariatric surgery, and that helps you to lose weight very fast. When you lose weight very fast, your insulin resistance comes down, and when that comes down, you need less and less dose of insulin. Even so far, as the journals say, you can cure yourself of diabetes by bariatric surgery by losing so much weight. That's quite a bold statement to make, but the journals have actually used that word cure. So by the time they get to seen at our clinics, it might be a 6 to 12 month wait, but ultimately they do get seen, and so it becomes much, much nicer for the patient and easier for us, and then we can do all kinds of things and get them really under control. And the final daily insulin requirement, it's about most patients 50 to 60 units in a typical type 2 patient. Usually higher in those with obesity and higher initial concentration of HbA1c and elevated liver enzymes. which are surrogate markers of insulin resistance and fatty liver. And when to stop your oral tablets? Now, generally speaking, I've just said about pioglitazone, the glitazones. Now they've got a bad name, so it's very easy. If you want to find one tablet to stop, that's an easy one to stop. And you have very good reasons to stop. The FDA have given so many black box labels to some of the glitazones, and even in this country, the LAD company has also given us letters saying rosiglitazone causes bladder cancer. So be cautious when using it in patients. So if I have a patient with metformin, gliclazide, and glitazones, I stop the glitazone first. Very easy choice to make. Then I continue the metformin and the gliclazide. And if they get troublesome hypoglycemias, it's the gliclazide which usually is the culprit. Another thing to consider is renal failure. If your creatinine is more than 150, they say it's a good thing to reduce your dose of metformin or even stop it. So when I sit in clinics, I look at the creatinine of more than 150. If the creatinine is more than 150, EGFR is falling. EGFR is 50, 60, 40, 30. It's going down, and it's when I start reducing the dose of gliclazide and metformin. And that's when insulin probably is the only drug they should receive. So some patients may wish to reduce the number of tablets they take, especially when they are already on multiple medications for blood pressure and lipid control. But if they want to reduce tablets for the sake of taking less tablets, they must be warned that you may need about 20 to 30 units of insulin extra for each withdrawn drug. And that might probably convince them to take it. So coming to this important flow chart, what I really want to point out is the initial dose of insulin right on top. 0.2 units per kg body weight per day. So which insulins can you use? You can use Lantus insulin at 0.2 units per kg body weight per day, or Novamix 30 insulin at 0.2 units per kg body weight per day, which usually equates in a healthy 70 kilogram individual about 10 units. If a patient is about 100 kilograms in weight, you can give up to 12 units, but not to go any higher than that for the sake of safety. The patient is bound to get a bit frightened. Why are you giving me 20 units to start with? So yes, start slow and go slow. Start with an 8 unit or a 10 unit or a 12 unit. And that's why 8 units of Lantus has got the name familiarization dose, just a familiarization dose. And we do that even in our clinics. We just start them on 8 and 10 units. It's totally safe with them. You can start on that. Now, the ideal way of doing things, which are difficult in real life because your patients have jobs, your patients have families, it's difficult. The ideal way of doing things is that every 3 days they should be increasing their units by 2 units every 3 days to make sure their blood sugars are within the target range of 3 to 7.2. So they should be measuring their capillary sugars before and after meals in an ideal world, 6 such readings in a day. A 7th reading should be taken before bedtime. And if those readings are above 3 to 7 millimoles per liter, then they should increase that insulin dose you give them by 2 units. But in real life, that's very difficult for your patients. They have jobs, they have careers, they have children to look after. It's really difficult, social reasons. So for them, we, instead of 2 to 3 days, I say 2 to 3 weeks. Every 2 to 3 weeks, you can increase it, very busy people, by 2 units if their blood sugar is above the target. And HbA1cs are best done every 3 months. And why is HbA1c best done every 3 months? Because the red cell count turnover is 120 days. So that's why we do it every 3 months for HbA1c. Now, not to frighten you, it frightened us last year. We went for a diabetes conference, and you know HbA1c is given in percentage figures, and at the bottom you have another unit, IFCC unit. Now they want to internationalize it and say all of us should be reporting HbA1cs with those units, those new units, and not percentage figures. It was shocking for all of us when we went to the conference. We said, why are you doing this? Apparently it's for the sake of the patients. Patients, if you tell them an HbA1c is 6.5%, they mistakenly think the millimoles per liter of the capillary sugar is 6.5%. And to make it easy for the patients, they try to get us all to use the IFCC units. Now the good news is it hasn't yet reached our practice yet. We're still using percentage figures. We're very happy with it. For the next 2 years, we're still using percentage figures. But just bear in mind, it's a bit like a tsunami. It's heading towards us. And we just have to keep in mind something like this can happen in the next 2 years. But we'll give another talk when it comes to that. So from the GP point of view, from the community point of view, the bottom line message is to start with 0.2 units per kg body weight starting dose, something safe like 8 to 10 units, and then increase it in an ideal world. If the patient is very pedantic, you can increase it by every 2 to 3 days by 2 units. But if it's a typical patient who's very busy, career, mother, father, for them every 2 to 3 weeks, you can increase it by 2 to 3 units until the capillary sugars are within the target range. Then I thought I'll speak about this insulin, Novomix 30. Novo Nordisk are very happy about this insulin, and I also like this insulin. And perhaps if you can start it once a day in the community, it will be of great help. And you can leave it to me to give it twice a day and thrice a day. In the hospital, I can easily do that with my diabetes educators and get the patient well controlled. Another similar insulin to Novomix 30 is Humalog 3070. That's another one, very similar to Novomix 30. And the same principles apply to both. You can start with 0.2 units per kg body weight per day, which is about 8 to 12 units in a day of this insulin. You can usually start it at night time, and this is how it behaves. This is how it's going to raise your insulin and push it down. And it will not last for 24 hours. That's the catch about it. It lasts for about 14 to 16 hours and stops over here. But at least you have some control. Your tablets will give the rest of the control, and the months will pass. They'll come to my clinic with a much better HbA1c. Then I can work on things. And if they come to my clinic with a worse HbA1c, we have strategies for that. I will give them twice a day Novomix. Not only will I give it at dinner, I will also give it at breakfast. And if they come to me with even worse readings, then I will give it thrice a day. I have the slide 3 injections. I'll give it thrice a day. Breakfast, I'll give it at lunch, and I'll give it at dinner as well of Novomix 30. These slides were to show how much of HbA1c does it bring it down by. So these were studies done by the drug company, so it must be taken with a pinch of salt. But they do claim that their HbA1c is brought down, almost comparable to Lantus. So you may ask me which one to give, Lantus or Novomix 30. The results are comparable. In terms of bringing down the HbA1c, the results are comparable. So you can use either Lantus or you can use Novomix 30. You can start at bedtime, you can start 8 to 10 units at night time, no problems. So the conclusion is, the inevitable need for insulin therapy in most patients is best discussed early in treatment, and the need of insulin is not imminent. And the message should be continuously reinforced to patients because it helps to set their expectations that one day they may need insulin, and it eases their transition to insulin later on. And sometimes giving practice injections using saline can also help in the practice. And in the olden days, they used to use it into an orange, but we don't use such large syringes now. So a practice dose of saline in the human body can be used to teach them how to give insulin, and it helps the patient get more confident with the needle. And diabetes educators are an optional additional source of support and information for these patients in this important healthcare change. Before I go to the second section, I was also asked to mention something about whom to refer to clinic. So feel free, all the patients who are not doing well, feel free to refer them to clinic.